virtual senior fair. My name is Abby Marsegan. I am the Director of Admissions of Lexington and Lake Zurich. Lexington Health Network offers healthcare and living options to seniors. Lexington has 8 skilled nursing facilities in Illinois: Chicago Ridge, Bloomingdale, Elmhurst, Orland Park, Lombard, LaGrange, Schaumburg, and lastly but not least, Lake Zurich, that provides post-acute rehabilitation needs. We also offer independent, assisted living, and supported living options for seniors. And with our diverse network of healthcare services, we also offer home health care, hospice care, and private care services. This next class is about nursing homes to post-acute care networks, presented by Fred Benjamin. Fred Benjamin is a Chief Operating Officer at Lexington Health Network. He has a master's in business administration from the University of Chicago, as well as a master's in public health from the University of Illinois. He has had 25 years as a CEO and also a COO at 3 different post-acute companies. He also serves as a member of the Board of Governors of the American Health Care Association and the Illinois Healthcare Association. With no further ado, here is our wonderful Fred Benjamin.
Thank you, Abby. I appreciate it. I will try to live up to the big intro. I'm delighted to be here with everybody, and just some ground rules for the presentation. I'd like this to be as interactive as possible. So if people do want to ask questions, put them in the question queue, and I'll be happy to try to answer some of those. As I was trying to conceive this program several months back, the topic of networks seemed like it was an appropriate one to talk about, because I think people in general do want what system of care is out there to take care of our elderly. But something strange happened on the way to the fair, and that is COVID. So over the last couple of days, I've been fiddling around with my presentation a little bit and trying to make it a little bit more sensitive to the difficult time that we're all living through right now, and that would be COVID. You don't need to hear any more about my background. You've heard about that already. In terms of the agenda for today, I want to talk a little bit about the environment and how COVID's affecting that, the future landscape of post-acute care, and the challenges that are ahead, and then have some time, hopefully, for questions at the end. So the first slide looking at this is a picture of in general, how patients access services. So you can see in the upper left-hand corner, the patient may go to the hospital for a fall, for example, which are the most common reason for entry to a hospital for seniors. And they may spend some time in the hospital, for example, with a broken hip, or potentially with a stroke or something like that, and then end up needing some rehabilitation. And they traditionally go to a skilled nursing facility for either generally somewhere on the order of 2 weeks. That has recently changed, and over the course of the last, couple of years, people used to come and spend 60, 70, 80 days in a skilled nursing facility following a broken hip, for example. And now that length of time is approximately 14 days. It might go up to 20 days, but seldom longer than that. After an experience in a skilled nursing facility, people generally have some home care provided. These days, people from the skilled facility and or people from the home care company will come out to the person's residence, if that's in an independent living facility, or to their home, and do an evaluation of their home environment to see, for example, if there are stairs or if there are carpets or other things that might cause safety problems when somebody is sent home. So at the second line, you can see that the kinds of services that are provided in these various environments are naturally different, with the most comprehensive being provided in the hospital, but a not too different level of clinical sophistication being provided in the skilled nursing unit. And I would add at this juncture that something that has made a huge difference in terms of the level of care that's provided in skilled nursing facilities has been the addition of telemedicine. Telemedicine has allowed clinical specialists, subspecialists of various types to see and evaluate patients while they're still in the skilled nursing facility, and sometimes at their home as well, providing an additional level of capability for us. At the bottom line, you can see, not surprisingly, that the cost is the highest in the hospital, generally running in the thousands of dollars per day. In a skilled nursing facility, the average reimbursement from Medicare is approximately $600 per day that the facility gets, but they have to pay for almost everything that is provided out of that money, out of that reimbursement. Home care can generally is about somewhere around a third of that, and assisted living and independent living are a different kind of financing arrangement. But long story short is that they can have a variety. You can have a variety of different kinds of services provided in your home. The difference between an assisted living facility and a skilled nursing facility, generally speaking, is that the assisted living facility has a private apartment with a lockable door, and skilled nursing facilities typically do not have locks on their doors and generally provide 24-hour nursing coverage, meals 24 hours a day, a variety of other kinds of services, some of which may be provided in the home care environment as well. So moving to the next slide, some of the key trends, some of the key things that are happening in post-acute, and this is really right up until about March 1st, somewhere around there. And these things will continue to be important trends as COVID begins to ramp down. And these things include heightened expectations on cost and quality, not surprising there because the government is paying for the vast majority of services provided in skilled care. Narrowing post-acute care networks, meaning that this is an interesting phenomenon that I would imagine most people on the call don't know about. The kinds of services or the kinds of opportunities within Medicare are changing. There's the traditional Medicare program where you have your Medicare card and you access services through your doctor or hospital. Well, that Medicare program, Medicare A and B, and C and D, and results in about significant amount of copay, meaning that the patient has to take money out of their pocket to participate in the payment for that care received. The new kinds of Medicare are ones that so-called Medicare Advantage plans. In these plans, seniors trade in their regular Medicare card, and they get a card from a new company, for example, United Healthcare or Optum or Humana or accountable care organizations sponsored by hospitals. And at this point, about half of the Medicare beneficiaries have these other kinds of plans. And that causes a whole lot of confusion when people are referred from the hospital to a skilled nursing facility because they control where the care is provided at the next level of care. They essentially become the agent of an insurance company. They are the insurance company, and by virtue of doing that, they decide where the patient goes for care and how long they stay there, and a variety of other things, including how much we get paid. So they have the incentive to provide the appropriate level of care and the appropriate environment. And because of the improvements in the quality of care that are provided at home and the technology available to be brought to people's homes, including telemedicine, they send people home from our environment, home, or to the assisted living environment a lot quicker than they used to. People now stay in our buildings for about half the length of time that they did before. But the good news there is that approximately 90% of the patients that come to us go home safely and transition back to their previous lifestyles. So But at the next key trend is care is migrating to home and community-based settings. I already covered that a little bit. Just to add that more and more people want to go home. Nobody wants to be in a hospital. Nobody wants to be in a nursing home. They prefer, generally speaking, to be at home. But being at home is not a panacea either. If your spouse has passed, you can be isolated and lonely. So sometimes these other community-oriented living arrangements can be just the right thing. Another key trend is unlocking the potential of healthcare information technology. Clinical and business models that in post-acute now have very sophisticated EHR, so-called these clinical records, and can track patients through systems, can track patients' progress, and not just their medical records, but literally how they're doing. And there are so-called predictive analytics now that can predict when people are going to have problems. And so these are really important and will be increasingly important as we move on. Something else that's happening, I mentioned a minute ago about narrowing post-acute care networks, meaning that the hospitals, hospital systems, and insurance companies, they are using quality metrics to decide who to send people to and also who not to send people to. We're fortunate at Lexington in that we are key providers for many of the larger healthcare systems in the city based on our quality statistics, and because we have excellent quality statistics, we have been asked to participate in some of these insurance relationships and to take financial risk along with our hospital and insurance company partners. And that one is not necessarily that we want to do that. It's that we have to do that in order to continue to be in their networks. So moving to the next slide. This is one of the new slides that I added, and I think that probably one of the things that people when I talk about skilled nursing facilities, this is the first thing that they want to know. Why has COVID-19 hit skilled nursing facilities so hard? Well, first and foremost, SNFs have the most vulnerable population. We have the elderly and people that are over 65 have an enhanced risk. People over 75 have an even more enhanced risk. People over 85 have the highest risk of getting sick with COVID. And not surprisingly, the average age of the population in skilled nursing facilities is north of 80 years old. And so we have a vulnerable population in that just by virtue of age, but also because of those with many other clinical conditions, including morbid obesity or obesity of any type, lung diseases, any prior history of diabetes, or any of a variety of different diseases. And in spite of all of this, when COVID began to hit in the United States, skilled nursing facilities were nowhere on the priority list. Hospitals were on the priority list. They were in the news every single day. And I'm not criticizing our hospital partners at all. They were just trying to survive the same way that we are. And so the supplies of PPE, of masks and gowns and all variety of supplies were directed to them, but not to skilled nursing facilities. That's a problem. That's a problem because COVID is highly contagious, and not surprisingly, individuals that have been exposed to COVID, i.e. our workers, and until our facilities were locked down, they could have COVID for 5 days without symptoms, not know that they had it. We wouldn't know that they had it, even if we do temperature testing, and if they had a COVID test walking in the door, we still wouldn't be able to tell if they had COVID. Consequently, for a long period of time, people that were carriers were coming into our facilities and inadvertently contaminating, infecting others with COVID. The lack of PPE has been just horrific. Our company has spent over $2 million since the start of March on additional PPE, including masks and gowns and gloves and all manner of things. And there are still major shortages of all of these items. And within the first 2 months, we had made orders of $100,000 plus of masks, for example. And then a day or two before we were supposed to get the masks, found out from the company that our government had redirected the masks that we had bought, ordered and purchased to hospitals or county health departments. That was really difficult. Next, the lack of testing. We still have significant difficulties in getting test results back. It's taking on the order of 5, 6, and 7 days sometimes for us to get test results back, and that makes it really difficult. However, we have been very fortunate. We have been exceedingly scrupulous in our infection control procedures, and we have, for the last 45 days, I think we might have had 2 or 3 additional cases of COVID in our facilities. So we've done a very good job, and I think the skilled nursing industry in general has done a pretty good job of getting their hands around it after getting this experience. It's important to remember, though, that nobody knew what COVID was about. Still don't know a lot about the infectious capacity, how it's transmitted. We still don't have a vaccine yet, and we're still in a major in terms of this. And we have also a great difference of opinion in different parts of the country on the use of masks and on the use of social distancing. That's not helping, I can tell you that. And then here also, the lack of a coordinated approach by various government agencies, the county, state, and federal government. We and the hospitals and the doctors have been getting conflicting information from these different agencies, and it's really hard to do the right thing. Even if you want to, you're spending all kinds of money on staff and whatever. It's still hard to know if what you're being held accountable to, or what the best treatment options are, if the various people that are your regulators are telling you different things. So that's kind of a snapshot of what our world has been like.
Fred, I have a question, or there's someone who sent a question.
Yes, please.
They said, can you please address changes in SNF to keep patients safe and sane since the pandemic?
Well, exactly. That is the next slide that I put up. So thank you for that great question. This is only a partial list now of the precautions that we have taken. Please know that many of these precautions that have been sent to us by the Centers for Disease Control, the Center for Medicare and Medicaid Services, various state, federal, county authorities, we were doing most of these things before being asked. We have an entire clinical team that at our management company that follows all of these various rules and regulations for our facilities, and we keep a very close eye on these changes and implement them as soon as we know about them. And sometimes we hear that they're considering doing this or that. If the idea makes sense to us, there's no question we will implement it even before we're required to. So some of the things when our staff, first of all, there are no visitors that are allowed into our facilities at this point, or any skilled care facilities. At a second level, people that do come in, i.e. our staff and or periodically a vendor, we have very strict screening policies for them. They have to have their temperatures taken. They are physically examined to make sure that they don't look sick. We ask them to complete a form that attests to the fact that they're not feeling ill. We get their name, address, and telephone number so that we can do contact tracing if they are, and we require them to wash their hands and or use hand sanitizer. And we have been doing this since the first part of March. As I mentioned, we've purchased over $2 million worth of PPE, and that number increases every week with new orders and new supplies. We don't see that changing at any point soon. Increased and now insofar as our residents are concerned, increased respiratory and other clinical surveillance. Somebody is checking in and visually looking at patients, taking temperatures, et cetera, on the average of about 8 hours. For people that are under suspicion of getting sick, nurses are in their rooms between 2 and 4 hours. So we're looking at our patients on a very consistent basis. Insofar as how our facilities are organized, we have the same people taking care of the same residents on the same units every day. So we minimize the chance for staff spreading an infection that they don't know about to other units. We also have physical units where people that do have COVID are housed so that they don't inadvertently spread COVID to other residents. And these areas are cordoned off with thick plastic sheeting, and people are not allowed to move from one geographic area in a facility to another. All of our dining is in room, all of our therapy is in room, all of our activities are in room. So as you can imagine, it's a lot more expensive and a lot more complicated to provide all of these services individually in people's rooms. As I mentioned, we have very extensive use of telemedicine, extensive use of personal protective equipment, and testing for staff and residents. And we continue to follow the guidelines of our various state, federal, and professional agencies. So hopefully that will answer your question. And there's a lot more that we're doing beyond this as well.
Fred, we have another question.
Yes.
The person would like to know what is independent and assisted livings under HomeLink. So I don't.
What is independent and assisted living under
HomeLink?
HomeLink? I think I understand the question. But assisted living is a venue. It's like an apartment building essentially that offers various kinds of supportive services. Those services include meals and meal plans. Generally, assisted living facilities provide 2 meals a day, and residents can pick which of those that they want, or they can have 3 meals. They have some limited nursing assistance. They can help people to manage their medications, but they can't because they're not licensed to do so. And this depends on the state licensure in every state. But generally speaking, the resident, a nurse's aide or somebody can come into the room and put the medications out, but the resident has to physically take them themselves. They may have memory care units, memory care services in them, and there are also some facilities that have independent living, skilled nursing, and assisted independent and skilled all on the same campus and on different floors. So hopefully that answers the question.
Thank you.
Okay, so one of the other things that at the start, there were over the first roughly 6 or 8 weeks of COVID being identified by the press for all the problems that skilled nursing facilities were having in taking care of COVID and trying to understand, just literally in real time, trying to understand what was going on and what we could do to try to prevent the spread. A variety of different researchers, 3 key ones though, from Harvard, Brown University, and the University of Chicago did a significant study. And what they identified was that the location of a nursing home was the determining factor in outbreaks, according to their analysis. And what this showed really was that in communities that had high penetration of COVID, the people that lived in those affiliated nursing homes, not surprisingly, were at much higher risk. And again, this was caused by not being able to know that who had COVID and who didn't, and because of the lack of testing to determine who did, and the turnaround time of testing once it was identified as being in the building or suspicion of being in the building. So what are the implications of having COVID in skilled facilities? Well, the first implication is that we have to rebuild our relationship. Most of the stock of beds in the skilled nursing world across the entire country are semi-private rooms. A much smaller number, less than 10% of buildings are all private rooms, and a smaller number than that have private rooms with private baths in them. And consequently, consumers and the children of people that are being shown to the skilled nursing facilities or referred to skilled nursing facilities are worried, and appropriately so. And this is a big worry for us, for our company, and for skilled nursing companies across the country about how we need to organize our facilities and how we can assure people that are evaluating our services that they will be safe, and that we are minimizing the chance for others to be infected. And we have been working very hard on that, on some physical plant redesign, and also in terms of how care is being provided. The one thing I can tell you is that all these various approaches have in common is that they are more expensive, a lot more expensive. And so far as that is concerned, I don't expect people to have tag days for skilled nursing facilities, but I can tell you that Illinois is 42nd in the United States in reimbursement, Medicaid reimbursement for long-term care, because Medicaid is about 2/3 of our business, and on average all nursing facilities in the United States. And so if they're paying us less than our cost, somebody else has to pay more than that, than the actual cost, so that we can break even. According to the Centers for Medicare and Medicaid Services, the average margin for skilled nursing facilities in the United States last year was minus 0.5%. So lost 50 cents on every $100 that they took in. So that's a scary number, because you can't survive in the long term, and you don't have the money to replace the physical plant and to do the things that are necessary to provide additional assurances, private rooms and private bathrooms, for example, for our customers. So we're working pretty hard trying to figure out what the next phase will look like for us. The second implication, obviously, a lot of people are going home, and hospitals for a while were sending people directly home because of their concerns about people that were just released from the hospital getting COVID. And for those residents, that has not necessarily been an easy situation, because those people are generally pretty sick, and skilled nursing facilities have played a crucial role in taking care of people like that. As hospital expenses have continued to rise, the length of stay in the hospital, the amount of time that somebody comes in and sleeps in the hospital, has decreased. When I started as a young hospital administrator a long time ago, people came to the hospital and spent in excess of 30 days on average. The average length of stay in the hospital now is about 2 days. Some people stay for longer, some for shorter, and so much of their volume has been pushed to outpatient that people that come to us probably were in an intensive care unit a day or two before. So the people that we're seeing are very, very sick, and that has caused us to have to add additional staff and additional technology, and the cost of providing that care is significantly higher. However, the third implication, non-traditional home care will enter the mainstream. And what that means is that there's the increasing explosion of technology that's available to take care of people at home, and driven in most instances by the availability and competence of telemedicine makes a big difference. Our telemedicine system, for example, has something called an electronic stethoscope, so that a doctor can literally listen to the stethoscope. He can have his or her cell phone and a pair of earplugs that he keeps in his pocket or her pocket, and can listen to the stethoscope sounds. They can get pulse oximetry results. We can do a 12-lead EKG, and they can physically see the EKG tracing on their home computer or their cell phone. They can look at the patient's chart in the hospital. They can look at the patient's chart at the skilled nursing facility, and in what's coming up next, we can have and of course we have the traditional Skype-like feature of the doctor and the nurse can look at each other. We're just about at the point that we can add the a family member in a three-way call, just like this Zoom call that we're doing now, and the family member can see the same things that the doctor does when they're both talking to somebody at the skilled nursing facility. So some great changes are coming that will help to take care of people in both the skilled nursing world and also at home. So the future state of what the skilled nursing facility will look like, it's not the skilled nursing facility anymore. It's a system of care, and that's why we call our company Lexington Health Network, because we offer not only skilled nursing facilities, independent and assisted living, and home care. We're able to coordinate those services across the different locations and have people like Abby that talk to their colleagues at the assisted living or independent living facility or in our home care company to make sure that when a patient is discharged from the hospital, that we can already have somebody that's going out to visit that individual at that individual's home to make sure that the home is ready for them once they are ready to leave the skilled nursing facility. We can make sure that their medications are there. And this coordination, it turns out, is very, very important. The reason that it's so important is that if we don't know what medications that the patient is on when they come to us from the hospital, or if the skilled nursing facility doesn't know the same thing to be able to warn the home health company, and there can be errors, there can be drops, if you will, in the coordination of care. When we have this whole system of care that is kind of overlaid with telemedicine, and that's overlaid with this ability to communicate, and for people in all these environments to look at the person's hospital record and skilled nursing facility medical record, we can know what medications they're on, and we can be prepared. I can tell you that there's nothing more frustrating than having a patient come to us from the hospital. So let's say an elderly woman who's had a broken hip or a stroke that is discharged from the hospital in the morning, and there's no communication or little communication between the hospital, or ineffective communication between the hospital and the SNF. And they might not get to the SNF. They might have been discharged at 10 o'clock in the morning. The resident might have had breakfast. The family member might not have had breakfast or lunch. They get to us in the late afternoon or early evening, and we don't have their medications ready for them, or we don't know what they've eaten for during the day. It's such a better situation for them and for us as well, when we can say, "This is Mrs. Smith, we're so glad that you're here. Have you had anything to eat today?" And to her daughter as well. "We have your medications ready. We just talked to your doctor." This coordination of care is the essence of making sure that things are working for the resident and for the family. So that's kind of the view to the new world that is coming, and that is being developed in real time now. But our environment remains very challenging, not surprisingly. Our patients are sicker, shorter lengths of stay. The expectations that patients and family have for us, they want hospital level quality. Our regulators are expecting the same thing from us. The quality of what we're providing is managed, evaluated, and tracked by the Medicare, Medicaid 5-star system, and everybody knows about that. Our reimbursement has been threatened, and as I mentioned earlier, we participate in various kinds of managed care arrangements, where sometimes they can even come back and so-called claw back money that they've already paid for us if we don't do a good job. And at the end of the day, everybody's paying slower because nobody has any money. Finally, our referral base are consolidating, and the relationships with the hospitals are changing too, because we used to have our marketing and sales reps at the hospital, physically located, visiting the hospital, and because of COVID, that has changed as well. So, long story short, marketing and referral management are much more computer driven and more difficult today than ever before. The other biggest problems that we have, and I expect to be done in about 5 minutes or so. I'm going to cruise through these last several slides because I want to make sure that there's more time for questions at the end. Our turnover continues to rise, and you think about who the caregivers are in skilled nursing and hospitals for that matter, but more so in skilled nursing. We have people that are making $12, $13, $15 an hour, our skilled our nurses aides. Those people come to work every day. They are the true heroes of healthcare. Not people like me sitting in an office or comfortably behind a desk at home. People that are getting up in the middle of the night, risking their lives, taking care of people that have COVID or coming to environments where there is a lot of COVID. We have created something called appreciation pay to give them a couple of bucks more per hour to thank them for doing this hard work, and frankly to keep them from leaving our employ, because we need them and our residents need them so desperately. But turnover rates have continued to rise, and that is a problem nationwide. The percentage of turnover attributed to employees with less than 1 year of service is also rising. It's in excess of 30%, and I've seen numbers in excess of 50%, depending on the state and the company. Here are just a couple of quick quotes from some people in this world. New RNs can't start with easy patients because easy patients don't exist anymore. It takes longer to get the knowledge and skill level we need among our new nurses, especially when there are more levels of knowledge and skill needed because of our environment. Not surprising. Here's a breakdown of the national skilled nursing workforce by 2030. 7 states now with a projected shortage of nurses by 2030. 39% projected growth in the number of RNs, and the projected growth in demand is about 28%. We will have an excess of nurses by 2030, but as you'll see in some of the following slides, the number of nurses that are retiring is very significant, and with that number of senior and experienced nurses, more new nurses are entering the workforce, and because of the shortages of nurses in universities and training programs, the number of people available to train those new nurses is going down pretty quickly. That's it for my presentation. I would be happy to take any questions or anything and talk about else that you'd like to at this point. Thank you for your kind attention.
Abby will read questions for you. I do have a question real quick. This is Jennifer.
Sure.
So Elderwerks does refer to skilled nursing facilities, including Lexington, based on our clients' needs. Do you feel, now this is a personal opinion, so, and we're being recorded. Do you feel that the quality of care is being affected by the Centers for Medicare and Medicaid restricting the amount of rehab you can offer in terms of days?
Medicare and Medicaid play an interesting game there. They don't tell us that we're restricted from providing the care. They just provide a specific amount of money that they believe should be sufficient to provide that care. If you have money left over at the end of that, it's great, and if not, that's your problem. There is a new reimbursement system that was just implemented the first of this year called PDPM, the patient-directed model for care. And what that system does, it's a generally speaking a good system. And what it says is that they're going to provide they're going to ask us to do an initial evaluation the status of the patient. That includes their activities of daily living and their so-called instrumental activities of daily living. What can they do? What were they doing before they came to us from the hospital? And they're going to measure the actual amount of improvement in their ADLs and in their clinical condition that we achieved. So that seems fair, at least on the surface. Unfortunately, one size does not fit all, because many of the patients, really almost all of them, are so sick when they come to us now. It's just difficult to measure that. And no two 80-year-olds are different. 1-year-old before they came to us was playing tennis, fell down and broke their hip or their shoulder. Another one had diabetes, is 70 pounds overweight in a wheelchair, and the trajectory of improvement of both of those patients is very different. So it's hard for any reimbursement system to fairly match up expenses and reimbursement.
Thank you. Abby, did you want to read the question that was there?
Yes, there was, I don't think this is a question. I think you just wanted to correct what you had said regarding Medicaid. This person stated, you're a facility that will accept Medicaid. If you fall under the income guidelines, many will not, and they are private pay only, or they will be private pay only.
Well, that is correct. I'm sorry if I left that impression. I absolutely agree with that. When I said 67% of the people in the United States that are in skilled nursing facilities are paid for by Medicaid, that makes no reference to if a specific facility does or doesn't accept them. And by the way, assisted living is very different. Assisted living, anytime you have a facility that accepts money from the federal government, they are to follow the guidelines of the federal government. So if you have an assisted living center that has a skilled nursing unit, it may be separately incorporated so that people that live in the AL, the assisted living part of the building, that's a private pay location, and they do not have to pay. They do not have to take Medicaid in that location. However, in the vast majority of the facilities in the United States are Medicaid and Medicare certified. There are very few that are not Medicare certified. Almost all of them are.
Thank you. There's another question. Is there better accountability for patients diminished now compared to when the pandemic started?
When you say, could you repeat the question? I'm not sure. Is there better accountability?
For patients dismiss, is that? Hold on, sorry, they redid it. Okay. Dismiss now compared to when the pandemic started. So death.
Well, I can tell you that we and everybody else in the healthcare system are learning as the pandemic progresses, as the hospitals and as skilled nursing facilities, as doctors and others have learned how to better care for patients with COVID. Patients that go to the hospital that are really, really sick, they have better techniques, and they've learned these things in a very short period of time. For example, having people sleep on their stomachs, looking at the amount of time that people are on ventilation, not putting people on ventilators early unless really needed. There are 100 different techniques that they've developed to take better care of those folks, and so have we in our skilled nursing environment as well. Some of those things included how we've segregated patients, how we've redirected our staff to take care of our residents, how we've used our PPE, how we've gotten more PPE, even though we've had to pay. We used to get, for example, N95 surgical masks for about 75 cents a piece. We've been paying in excess of $6 a piece. We use thousands of those per week, thousands, not to mention gowns and others. So we've really changed, and also we've had to not only increase the number of an amount of PPE that we've been purchasing. the guidelines have changed on how long you can use various kinds of masks and such, and before they have to be thrown out. So there are a variety of refinements in treatment techniques, and that is borne out by the fact that most nursing centers around the country are doing a lot better in keeping people safe, healthy, and the number of deaths in skilled nursing facilities has gone down pretty dramatically, happily so.
Thank you, Fred. Does anybody else have any questions? Oh, they wanted to know the number of deaths in the facility being reported.
Well, we have a lot of facilities, and I'm not going to discuss it. It's publicly available information. I don't have it at hand in front of me. I will tell you that we have had some patient deaths at some of our facilities. We have had other facilities where we haven't had any deaths at all. But across the country, here's a very sobering statistic that was provided by Dr. David Grabowski, who is the chief of the research, geriatric research at Harvard University. 12% of all skilled nursing facility patients in the United States have died as a result of COVID. 12% of the entire number in the United States. That is a very sobering number. We have not, by the way, at Lexington, nothing like that, even close, but still very, very scary nevertheless. COVID is the most efficient killing machine that our industry has ever seen. And because it has been able to go through facilities, because people can spread it without knowing that they have it, without being able to be identified as having it for 4 or 5 days, sometimes a week. And then people that have COVID, that recover from COVID, we still don't know how long that they're free from disease, or if they continue to be spreaders, even though they're not sick anymore, if they can still spread the disease. The research is not at all clear on if people can spread it after they've had it.
Thank you, Fred.
Sure.
Does anybody else have any questions? No.
I think that's it. Thank you very much for both of you for your support of the Elderwerks Senior Fair, your support of Elderwerks in general. We do appreciate it. So we wish you a great day and hope that COVID goes away soon so we can all get back to a little bit more less stress, maybe.
Yes, correct.
Thank you, everybody, for listening, and please feel free to call on us if we can help you in any way. Have a great day.
Thank you so much, and don't forget to fill out the evaluation form.